sometimes it's a little hard to tell if everybody's on, but I bet if I extend this introduction long enough, we'll all be in a good place to have a good talk. And I'm Dr. Vance Thompson, and what an honor it is to be here with you all this evening. Thanks for signing in, and we're going to have a good talk about the Rayner EMV lens. And I just finished a big day of surgery and just sat in my den at home, and I'm excited to talk to two of my colleagues who are well respected in the refractive cataract surgery world, and both Texans, Dr. Michael George and Dr. Jerry Hu. And I think I'll maybe ask my rock star participants that I get to have a good talk with about our experience with RayOne to introduce yourself. And maybe, Michael, I'll just start with you.
Sure. My practice is based out of Irving, Texas, which is in the Dallas-Fort Worth Metroplex. I have 2 offices, and I do cataract and refractive surgery, obviously, LASIK, a lot of advanced technology lenses. I've worked with, most of them that have been FDA approved since 2012. That's when I started practice. So nice to meet everyone.
Yeah. And Jerry, how about you? You mind saying a few words about you and your practice?
Sure. Thank you, Vance, for the nice intro. I am about 15 or 20 minutes away from you, Michael. I practice in Fort Worth, Texas, and also 2 sites and 1 surgery center and private practice. And I've been involved in premium channel IOLs, refractive surgery, cornea, for the better part of the last maybe 18, 20 years. Without diving into a long monologue, let's open up the conversation.
Yeah. And just tell you guys a little bit about me. I practice in my home state of South Dakota. Grew up in the middle of it in a little town, and I practice in Sioux Falls, South Dakota. And I do refractive corneal and phakic IOLs and refractive cataract surgery. And I have to tell you, 20 years ago, talking about advanced implants was less than 1% of my practice. I dabbled in multifocality just because of, a fascination with it. And, maybe those +5 hyperopes that I knew, would be able to take some of the optical profiles back then. But they literally have exploded, over the years. And, but we still have this, patient population that, maybe doesn't want to deal with, some of the dysphotopsias that come along with, trifocality, or maybe they were super happy with, monovision. But when you look at a technology, like the RayOne EMV, I first of all wondered, how long have you guys been using it?
The first time I did a Rayner lens was June 24th of 2021. So it's, about 8 months,
yeah,
or 9 months.
How about you, Jerry?
Well, Vance, I was just reminded that the first time I put in a RayOne EMV was in April of 2021. Now, the thing is, I remember I came out in practice, that was in 2002, 2003, and the crystal lens had just come out. And so I was involved in, refractive presbyopia correcting IOLs from the get-go. And for the longest time, as a country, like as a whole, our market share for PC IOL, had been stuck at 6%, maybe 7%. We add another 6-7% toric IOLs, but we've been stuck at 12 to 14% for well over a decade. And then finally, the advent of EDOF and also now the monofocal plus category implants, finally we're moving the needle. So I cannot wait to see where we're gonna take the market to, where the ceiling with these new technologies.
Yeah. And, you know, Michael, you're a great educator, and the way you approach a patient education, how does, if you could just briefly talk about how you do kind of your implant discussion and where this fits for us, that'd be just wonderful.
I'll try and make it short because that's a long, there's a long way to answer that question. Because a lot of it depends on what the patient's looking for whenever they first come and you meet them. If a patient's looking for, first I typically will first tell people there are lenses that there are the standard lenses that give you just distance vision, and they have the advanced technology lenses, and I'll usually jump from that comparison first to where I'll talk about the multifocals. And I'll give them the drawbacks that come with the multifocals. The technology is linked to the glare and halos around lights, and the decreased reading in low light. And then I will discuss the Rayner lens usually at the end. In my practice, I kind of use the Rayner as a midway point for those patients that are looking for some reading ability better than the standard lens, but at not quite such a high cost as the multifocals like the Panoptics or any of its peers. So most people that go with the Rayner lens, I find that they are pretty pleased with it, once everything's said and done. But exactly what we choose for their targeting does depend on what they're looking for in terms of reading ability and what experience they've had in the past with monovision.
Before we get into targeting, because I think you just brought up something super important for us to peel back the onion on, I'd love to hear, Jerry, how you're fitting in something like an enhanced IOL like this, whether you're using it, both eyes at a distance or enhanced monovision, how you're using a lens like this that extends depth of focus.
Well, that's a great point. I would like to think that Rayner will agree with me on this, although the topic of tonight is RayOne EMV, but really, we are not trying to fit RayOne EMV to every single patient. We are just trying to fit it to the right group of patients. I offer RayOne EMV as a monofocal implant. I do not, I will converse with my colleagues about the positive spherical aberration, the increased depth of focus, the widened defocus curve. But when I talk to the patient, I actually offer it as a monofocal lens. And I couple it with some other technologies so that we can be in an upgraded package conversation. So what I do is patients have very limited attention span. And I've noticed that once we go over 3 choices, they would draw a blank on their expression, they phase out and they retreat. They will go back to the standard or the traditional choices. So what I do is I limit my conversation to just 3 choices. So I tell my patients, you have the 3 choices. The first choice is the presbyopia correcting IOLs. The second one is the astigmatic management package. And the third one is the what I call basic implant packages. Now, once the patient has chosen the basic IOL package, and then I will give them another 3 choices. So I basically break this down and make it easier for the patient to digest the information. And then I said, well, you will be getting a basic IOL package, but then you also have just only 3 choices. One is called what I call precise vision package. That would include both the femtosecond laser and the aura, intraoperative wavefront aberrometry laser, and also the basic package. which, and the second package, that's where the RayOne EMV can fit in, is what I call a smart vision package. So I use Aura intraoperative wavefront aberrometry with an enhanced monofocal IOL. So that's where EMV fits in my offerings. And then of course I offer the basic package. And amazingly, so like I said, I mean, by introducing all these monofocal plus or enhanced monofocal lenses, we have been able to convert a lot of the patients who would have otherwise just gotten the basic IOL package. We've been able to upgrade them to sort of the mid-level packages.
The three choices I think is brilliant, and also, Michael's, how you want to do it kind of efficiently and keep it simple. And it's not just for us to run an efficient practice. These patients will glaze over with sensory overload. And so both of your approaches, I think, are just brilliant to give them this information in bite-sized, ways. And I think that before I get into targeting, would you guys agree? I mean, I feel like one of the reasons that an implant like this is so amazing, that will give us that diopter and a quarter of EDOF. I mean, monovision works for patients, but if you're not doing monovision with something like this, what I would call old pseudophakic monovision, the amount of distance blur you have to create without a lens like this, it's not unusual for patients to not tolerate it. And that's one of the reasons I worry a little bit about, monovision without something like the RayOne EMV. How about you two?
I agree 100%. Whenever you put a strict monovision with a monofocal lens, one eye's distance and one eye is a minus 151, 75, that near eye is going to be completely blurred out in the distance. It's going to create a lot of glare and halos around lights at night when you're driving. And people notice that blur even during the day, that one eye's blurrier than the other. And when you have an extended depth of focus lens like the RayOne, that point, wherever you choose for the target to be, they do see that point well, but they also see relatively well at other manifests, within a range around that point. So
right,
you don't have to worry so much about the distance not being adaptable, because the two eyes do fuse much better with a extended depth of focus lens.
I like the way you talk about range. I think that, this idea of extended range of vision is something that patients really understand well. And how about you, Jerry? I mean, monovision is still the most common way surgeons address presbyopia after cataract surgery in our world. I mean, so yes, multifocality has grown, but monovision is still a big deal to a lot of surgeons and patients. And how would you compare RayOne EMV, monovision versus, what we would call enhanced monovision compared to traditional monovision?
Yeah, that's a great point. I would go a step further and then I'll take a step back. So I'll go a step further by saying that monovision is not only still a great choice, but increasingly is a more and more common choice of our patients, who seek lens-based refractive surgery. And I'll take a step back, Vance, if you remember, right now, when I see a patient for LASIK, for example, 45 years old, or 50, more and more patients, they choose to target both eyes for distance and wear reading glasses, as opposed to a generation ago, their parents' generation, maybe 15, 20 years ago, I would say most patients would choose monovision approach. And then very few patients would target distance OU and then wear reading glasses. Now, 20 years later, these patients, you know, whom we have done LASIK for monovision, and also, you know, we may not have done LASIK, they just wear contact lenses for monovision. These patients, that segment of population, they have matured into the cataract age group. So right now, more and more patients that I converse with in clinic, you know, outside of the multifocal, you know, the EDOF, more and more patients, they actually choose, they want monovision approach with monofocal implants, you know, because they've done monovision with contact lenses, with LASIK, you know, all those years. And the difference is that with the monofocal plus lenses, they do offer this widened depth of focus. So if you look at the defocus curve, you know, the curve is broader, the top is flatter, so they can really extend into the other areas of focus, meaning the distant targeting eye can also see a little bit closer, and the near eye can also cover a little bit further out. So when we adopt monovision, you know, the curves, the defocus curves can really bridge the gap between the two eyes. And that really, for me, for most patients, you know, they maintain a very good stereo acuity, and we can reduce, you know, the imbalance, the asthenopia between the two eyes.
I love, Jerry, how you just present Michael and I with 3 bits of data so we don't get confused. I'm just having fun. I love how you treat your patients. But, you know, I agree with you guys. You know, it used to be we waited so long to remove cataracts, and now, you know, we have ways of, you know, identifying cataract as the cause of blur at a lot younger age. And we all know that our natural lens, you know, when we're 10 years old, has, you know, negative spherical aberration to offset the cornea's positive spherical aberration. And that's why young, you know, people have such good quality vision. That spherical aberration is really canceled out, and they definitely don't need it, you know, for reading range, because they have beautiful accommodation. But then as we get older and positive spherical aberration occurs in our natural lens, we add that to the positive asphericity of our cornea, and it starts to reduce low light image quality, and your parents are starting to want to drive home during the daytime and not at night. But that same spherical aberration that is starting to affect their nighttime image quality is also helping them read in bright light. And so some of these patients come in with early cataracts that are affecting nighttime image quality, but actually are giving them pretty impressive sometimes depth of focus in these early cataract patients. So that if you just do a traditional monofocal implant and someone who says, I don't really need that fancy multifocal, I'm okay with wearing reading glasses, but then you don't tell them that, you know, your natural lens does extend depth of focus, and you may find with a traditional monofocal that boom, your near and intermediate is quite a bit worse, and you're leaning on that bifocal a lot more. And you may even find that computer that you weren't having to go to a trifocal on, you're gonna have to now. And what I love about adding this diopter and a quarter of spherical aberration, especially in this younger cataract population that I see a lot of, and you guys I know see a lot of, you are getting that same spherical aberration that gives them a little bit more range, but you're still helping them beautifully with the opacity portion of the cataract. And so you don't find that dramatic loss of the depth of focus that was coming from their early cataract.
I think
Does that make sense?
That's a very important point. And I would say that part of whenever I'm counseling patients, I make sure that I explain to them, because I don't think that people always fully appreciate how poor the reading vision is with a monofocal lens when you're seeing 20/20. If both eyes are 20/20 in the distance with a monofocal lens, you have practically no reading, maybe not even J7 at intermediate. And some people are just not prepared for that because they're used to whatever they had naturally. And
Right.
with the Rayner lens, you get some intermediate even when you're both eyes are 20/20. You still have some intermediate.
Right.
And I've had patients that have some near too. They're less common, but with a Rayner lens seeing in the distance at 20/20, I have pretty good results for intermediate and some good ones for near.
And I think that's absolutely huge. And so, Jerry, your thoughts on this idea of a traditional monofocal. I think that, we pushed so hard to go get the image quality of an IOL that maybe had the asphericity of that 10-year-old, but didn't think about that the 10-year-old that also had beautiful accommodation so that they had range. And so going for all this asphericity to cancel out the cornea and not have any extended depth of focus like one of the, this type of, RayOne EMV can do. I just think we're going to be doing more and more of these types of implants versus what I call absolute presbyopia like that with a traditional monofocal. Your thoughts?
Yes, I think we really need to give the credit to Graham Barrett. There is a plethora of IOL choices. So honestly, when the rep came in from Rayner, to offer me the RayOne EMV, what really caught my attention was Graham Barrett. He puts his stamp of approval on the technology. It's his thing, And so I looked into the technology initially, largely based on Graham's reputation and his track record, And I was initially drawn to it by the science behind it. Traditionally, like you said, the cornea confers positive SA, and a youthful lens, natural lens, would give the negative, like SA, the offset. But as we get older, we not only lose the negative spherical aberration, but we gain positive. So if we look at all the implant design efforts in the last 15, 20 years, it's going the other way. We are coming out with aspheric lenses, either neutral with neutral SA or negative SA to offset the cornea. But Graham, came up with this idea of not only not offsetting it, but enhancing it, but adding to it. And voila, that really opens up a whole new door, a new way of looking at the solution. We are really pushing the boundary. The patients will get enough improvement, enough of a wow factor from the removal of the cataract already. So why not looking at the other benefits that we can get by stretching the focal depth? And I think the outcome and also the patient's feedback speak for themselves. We basically opened a new area, a new realm of possible solutions to tackle this problem. So it's ingenious.
Yeah. And speaking of Graham, we had a question on what formula do you guys prefer to use?
I run most of mine with Barrett too. If they have had prior refractive surgery, then we'll run the Ascaris online calculator as well, and I'll compare them between the two. I'm usually favoring the Ascaris for the prior refractive patients.
Jerry?
I usually stick with one of the Barrett formulas for my normal cases. And then for the post-refractive cases, I use Holiday 2 still. And for the shorter eyes, I use Hoffer Q. But again, that's a starting point. I heavily rely on Aura, intraoperative aberrometry. That has saved my my butt more times than not. And just anecdotally, before the advent of Aura, which I started using in 2011, my enhancement rate for the PCIOL market, the segment, I was stuck at 9%, 10%. I was doing LASIK enhancements on 9 to 10% of all my, restores back then crystal lenses patients year after year after year, despite, multiple K readings, multiple biometry. I was using LensStar, I was using our master, I just couldn't break that 9 or 10% barrier. But since I've used Aura, now, I enhance about 1% of all my premium IOL patients. And that has also transformed my LASIK practice. I mostly do primary LASIKs instead of enhancements of IOLs. So that's my take on the IOL calculation.
And Michael, as far as extending depth of focus, do you find that with something like the RayOne EMV that your landing zone, your enhancement rate? I would love you to comment on, your patient's image quality with, residual refractive error and how they handle it with a lens like this.
I can say most patients are very happy with their image quality. Most people are happy with the lens overall, with the reading, with the distance. We're pretty close to what we're targeting whenever we implant them. If it's off with the RayOne, it is less of an issue, I would say, than it is with the with a monofocal or even with any of the multifocals, because the being off a little bit doesn't affect the quality of the vision quite as much for these people.
That's what I find too, that low levels of, a spherical correction or cylinder are bothered, less with a lens implant like this. And I find that, especially with binocular summation, a real positive. Yeah, go ahead.
I'd say that we don't. At my practice, I include LASIK in the packages with the advanced technology lenses if they need it to fine tune the vision. So I know the enhancement rates for those. For the Rayner lens, we don't have LASIK included, but I don't think I've ever had to do an enhancement on a Rayner lens. No one's really had that big of a problem where they want me to do something.
And I think it's because of that landing zone just being wider. And so for a surgeon who maybe is doesn't have a laser, or they need to figure out where to send them if the patient wants more spectacle independence, I think you'll find the landing zone of this very pleasant. And I also want to emphasize, this isn't a lens that's just for people that want spectacle independence. You might have noticed me say earlier on in the program that, with a traditional monofocal, a lot of these, especially these, younger cataract patients, have to go to their trifocal a lot sooner than they used to. And these patients that don't mind wearing glasses, this lens pairs very well for them also, because they don't have to lean on that trifocal so quickly. So it can be nice for people that are looking for spectacle independence, with regards to enhanced monovision. But it can also be a nice lens for patients who don't mind wearing glasses. And so sometimes we have this monofocal side of our practice for people that don't mind wearing glasses, and then we have this multifocal side of our practice that for patients who want spectacle independence. And now we have a lens like this that works for both groups. Would you guys agree?
Yeah.
Yes, I do agree. Patients do achieve very good vision without spectacles. Hey, Vance, can we talk about targeting? Because we can't really talk about visual outcome without talking about targeting.
Let's
So-
go into targeting.
Yeah, yeah. So I understand nationally, globally rather, the average offset is about 3/4 of a diopter. That's the average. But in my, because I've been using it for about 10 months now, so I have gravitated towards two approaches. So when patients come in and they've chosen the smart vision, so they understand that they are getting a monofocal standard, basic lens, but they want a more accurate targeting with the aura. So I asked them, do they want monovision or do they not want monovision? So I have two different targeting strategies. For patients who have done monovision with contact lenses or even with LASIK, and they wish to continue with monovision, I would target, in that case, in the dominant eye, I would target plano. And if the two values straddle plano, then I would target, I would pick the first minus. That's for the dominant eye. And for the non-dominant eye, I actually go full mono. I target minus 1.5 diopters. Because these patients, they're already used to full monovision with contact lenses or LASIK. And the minus 1.5 would cover the intermediate range really well, and it can still reach out to distance, and yet it can still give them a full near vision. So those patients are very, very happy. And now, if patients do not request monovision, I actually only target about minus 0.5 or the second minus on the calculation sheet. And for those patients, I want to make sure that they do see distance really well, because that's what they expect. And if they can get intermediate, that's great. If they can get a little bit near, I think studies have shown that they can, in fact, get a distance and intermediate well. And 1 out of 3 patients can actually see near really well. But I actually don't tell the patients, I don't sell that as a marketing point. I go beyond under promise and over deliver. I do not promise anything at all. I just quietly deliver. I just let them experience it. Because after all, we are only offering a monofocal package. It's not a presbyopia mitigating package. Now, if they want that, we have other packages they can choose from. So I don't oversell. I don't over rely on this technology to really bring in the patients who really want that near vision. So patients actually, they expect distance, they will get distance, and they get intermediate and near. That's on the side, and they're happy because it's really unexpected surprise. There are pleasant surprises for them.
Wonderful. And Michael, how about you on targeting?
Very similar to Jerry. The patients that have had monovision before, I'm a little bit less near targeting than he is. I usually will go around a -1 to a -1.25 target, and he was saying about a 1.5. And I don't find that they have any problem with that. I rely on that extended range. If you had a monofocal with your monovision, a 1.5 would give you a good reading. So I found that with this lens, I can go around a 1.25 or even a -1. They get better distance that way. They get, from what I can find, about the same near as what they would get with a monofocal -1.5. So they're all very happy with that. For the patients that haven't had monovision, then just like Jerry, I'm doing about a -0.5 to 0.75. Depending on how much reading is important to them. They kind of, if it's more important, I have that discussion, then I may be going from -75 to -1.
And I think that, one of the reasons that monofocal monovision traditionally patients were, having a difficult time is they really would have a hard time ignoring the near blur in that distance eye, since it was just such a, precise focal point at a distance, that near blur just didn't marry well with the monovision eye. And so what's nice about a diopter and a quarter of extended depth of focus in a lens like the RayOne EMV is you're really, and I think you, Michael or Jerry, one of you alluded to that you're really lining up two ranges, you know, rather than two distinct focal points. And I think that's the other reason that patients, you know, just tolerate it so well. And so how have your outcomes been? I would love to hear, you know, how your patients enjoying it. You used to do more maybe traditional monofocal monovision. Are you finding that, you know, all these optical principles we're talking about are translating into happier patients?
So to respond to how the outcome's doing, if I target an eye for the distance 20/20 with a Rayner lens, the distance vision in assuming they get 20/20, they're very happy with the distance vision. The reading vision is typically somewhere between J3 to J5, sometimes J7, but the majority of my patients cluster somewhere in that range. Usually it's about averaging J4, J5. But we do get some J3s. I've had a couple people that are 20/20 distance in J2, but not much smaller than that. When you put in a -50 target or a -75 target, then you're more likely to get that J3. And you know, if we put in that -1 to 125, I usually can get people down to J1.
How about you, Jerry? Patient outcomes, how they
Yeah,
been?
I've done several dozens of them. You know, in fact, I just had my research team pull a spreadsheet of all the patients. You know, I review them. You know, not enough time to email and put on the screen. So, like I said, you know, depending on how I target, in the dominant eye, which I target plano, almost all the eyes saw 20/20. Okay. And in the non-dominant eye, you know, that I target -50, at distance, these eyes saw 20/25. Okay, so you don't lose a whole lot of distance. You know, it's yeah, they hardly notice any difference. Now, for the monovision group, you know, amazingly, maybe because of, you know, the way that we refract, you know, they didn't push plus. Some of the patients, you know, there's a wide range of, you know, the eye can, you know, the defocus curve is wide and the top is flat. So those patients, they can refract anywhere between -150 and up to -2.5. And the one patient even we fogged to -3 was even seeing well. So that really attests to how wide and flat the defocus curve is. And in terms of the reading, you know, I echo Michael's observation that most patients, you know, actually saw J5, okay, and some patients can see J3, and some, you know, didn't fare as well. You know, they see J7, okay. Now it all depends. If we mention, you know, if you alluded to possible intermediate, possible near, whatever, once they have any expectation, they can only be set up for disappointment. But when I talk to my patients about this, unless they do monovision approach, I don't mention anything about intermediate and near. And when they don't expect and they see the J5 or J3, they're happy. You know, we have been burned by the symphonies, you know, of the yesteryears, you know, by the restore active focus. You know, once, you know, on paper, even if patients see J2, you know, we are applauding ourselves for being successful, you know, for being able to deliver J2. But we spend most chair time trying to placate those patients who see J2 and unhappy. So in my experience, to really talk about, present this as a presbyopia mitigating technology, unless the lens can offer J1, J1 plus, I would be very, very careful about over-promising or promising at all. So, but again, with RayOne EMV, I'm not promising anything. And patients see 2020, 2025 in the dominant eye, maybe 2025 in the non-dominant eye, and they're happy. They're happy.
I think one of the things that is a reason why sometimes we see variability in near and some do surprisingly well is the spherical aberration or the high order aberration profile of their cornea, in addition to a lens like this, can sometimes really surprise and delight up close and at intermediate. So we got this variable multifocal lens in our cornea that sometimes gives us more depth of focus than we might have predicted. And that's why it's nice to quantify those HOAs, preoperatively, because it helps you even in your patient discussions about trying to make sure their near expectations aren't too high. So for doctors that are, looking into getting into this type of lens, I love the injector. I love the, haptics. I think it just auto centers beautifully. And I love how it's, not pupil dependent. It's a beautiful optic. But when you start talking about extending depth of focus, a diopter and a quarter, some doctors will worry about dysphotopsias. And I would love to hear your experience with dysphotopsias. Michael?
I have not had really any complaints.
Yeah.
that I'm
And Jerry?
aware of.
Yeah, same. If you look at the optics, this performs, looks, feels like a monofocal implant optic. You don't see any apodization rings, you don't see any achillettes, you don't see any transitional elements. It looks good, And although when I talk to patients, even if they do ask, they do bring up the topic of dysphotopsia, I don't tell them that this implant does not give any. I just tell them that among all the available implants that we have on the market, this and the other monofocal implants would give you the least amount of dysphotopsia, but not zero, because I do mention that to them, it's not zero. And that actually paves the way for me to discuss about multifocal as well, because multifocal implants will give you more dysphotopsia, but the reference point is not against zero, but yes, against less. We all have had patients who've had monofocal implants, but they are still bothered by night vision disturbances. So I tend to under promise. When I under promise, when we emphasize what the technology can do, but when I overemphasize what the limitations of the technology is, I always end up in a better place.
Well, good. Well, any other tips that you guys have for the users out there with, this type of implant, as everybody's looking at something like enhanced monovision or slightly extending depth of focus, a diopter and a quarter in really a monofocal platform, but an enhanced monofocal platform. Any more tips or advice that we haven't talked about?
Well, we haven't really discussed the differences that the lens has when you're doing the surgery and injecting it in. And there's questions that they've been asking, and I answered one about the injector. The injector, I would say, I like the injector because it's very easy for the technician to load. You don't have to worry about them scratching the lens. They don't really even have to handle the lens itself. It's already there. They just squeeze. The difference, though, between that injector and some others is that it's a plunger injector, and others are screwed. And the Rayner lens, I find at the beginning of the injection, it's very easy to push the lens along in the injector. Whenever the lens optic, the center of it gets to the thinnest point right at the tip. The pressure that you apply needs to be firm, but not intending to push too fast, because once you get past that point, then it will come out a little fast if you're not expecting that. So that's the only caveat I would say that I have about with the injector, but it is very easy to get used to. It's just, I would say the first time you do it, you would want to make sure that you knew that it's going to get a little tighter right in the middle, and then it's going to come out a little bit loose right at the end.
Do you do it one or two-handed?
I use both.
Yeah. Okay.
Mm-hmm. Yeah.
Jerry, any injector additional
Yeah.
thought?
Yeah, I'll echo, a couple of points that you both made, and then I'll have another point. First of all, I really like the C loop, or the closed loop, the anti-vaulting haptic. I think it self-auto centers really well, and also it confers great rotational stability. Of course, we only have the monofocal and now the monofocal plus in the U.S. market, but globally, Rayner is really known for its robust line of products. They have the trifocal, they have the torics, they have the Sulcoflex, the sulcus-based supplemental IOLs. So at some point, we're hoping that this is just the first foray into the U.S. market by Rayner, and we will also be able to benefit from the wide array of implants. Now with the auto self-centration, the multifocal, trifocal platforms, they'll work great. And also with the rotational stability, in my experience, I don't know about you, Vance and Michael, I think this closed C loop, the anti-vaulting haptic really offers the best rotational stability on the market. I really think it's on par with the old Crystal Lens Trueline, like with its 4 foot plates, and also it's on par with the Technis Toric 2, with the all-around frosted edge. I mean, that thing, once you leave it and align it along certain axis, it doesn't rotate. So that's wonderful, for future iterations of like other models. So that's the haptic. Now the plunger, I love this plunger. I would also say that it's my favorite preloaded IOL system on the market right now. Number one is, the nozzle, I believe it's like 1.65 millimeters. So technically it can go through a 1.8, but I don't do 1.8. I do a 2.2 millimeter wound, and it can go easily, into and through the 2.2 millimeter corneal wound without fish mouthing the wound. So that's really good. And Michael really explained really well, the benefits of a one-handed plunger system. With a one-handed plunger, you can use the other hand to stabilize the eye by holding onto the eye through the paracentesis. And that keeps the eye in the middle, and that keeps the eye, in the center of the view under the operating microscope, and the patients are comfortable, And when I use the two-handed screw type, I really, and also if the nozzle is wide, I really have to use a wound-assisted technique. You basically push the eye all the way nasally, like away from us. And the patients hurt, I mean, I really think the reason for them to feel the pain is not the pressure per se. It's really, we're rotating the eye so much. We are really stretching the lateral rectus muscle. And that's really the main source of pain and the discomfort. But I enjoy now we have a number of new lenses, as you know, on the market. Great optics, great implants, Synergies, Eyenses, they all coming with the preloaded screw type, wider nozzle, so I'm going back to having to explain to the patient, hey, look at me, you're gonna feel the pain, I'm going back to relive that kind of life again. But whenever I do RayOne EMV, the OR is nice, it's quiet, it's smooth, the patient is comfortable, and I can carry on my conversation with the patient, with my nurses, my visitors. I don't have to interrupt my conversation. It's just wonderful to have a one-handed operation, a plunger type a cartridge with a narrow nozzle. Okay, so I echoed your 2 points. Now, the other thing I want to add is for surgeons who may be watching this Zoom meeting and who may be considering to try this, it's about patient selection, which candidates to really avoid, now remember, we don't have the toric version yet. So I would say to make patients happy, I would pick candidates with less than 1 diopter of corneal cylinder, because we don't have the toric models. We don't want to significant astigmatism, and then if they don't see well, then it's really not fair to judge the merits of the implant based on that experience. And the other thing is, if a patient has had a high degree of myopic LASIK or multiple incision RK, 8 RK or 12 or 16 RK incisions, their corneas are already very oblate. So they already have very high values of positive spherical aberration. I'm not sure, I may need to ask Vance, and maybe ask Graham. I would think that, once you go above 0.3 microns of positive SA, you may be okay. But if you go over 0.5, 0.6, how much degradation of the image quality will be, in order to gain the stretch of the focal point. So I personally, I still avoid the high myopic LASIK or RK patients just to keep the positive SA under control, so it's not overly high. Okay. And also the last point is the large angle, the angle alpha. I really think angle alpha in my practice is more important than angle kappa, and because this implant self-centrates so well. So it self-centrates to the center of the limbus, the bag, okay? Now, if the patient does have a high angle alpha, so if the visual axis is significantly off of the axis from the limbo axis, the limbo center, other implants with the 2 haptics, we can still nudge the center of the implant nasally to align the center of the ring with the Purkinje image, so that we line up the visual axis with the center of the implant. But with this, you really cannot nudge because it's going to self-center. So I wouldn't put a patient with large angle alpha as my first patient to evaluate this implant.
I guess I'm probably a little less worried about that. I've felt that these implants with less spherical aberration, and we're not going for a full EDOF or a full multifocality, are less sensitive to decentration. I do look at the indices. I look at the corneal HOAs, and someone who has a high angle alpha or angle kappa, we will talk about that. And I will even mention the possibility of an implant exchange potentially being more, but it guides me in that type of discussion versus ruling them out. And I've found with this lens, the RayOne EMV may be a little less sensitive to those centration issues. But again, I think that's one of the beauties of this class of implant that isn't quite that premium EDOF, designation, but, isn't a traditional monofocal. We're extending it 1.25 diopters. And thank you for mentioning the toric. We don't have that yet, and it will be. I know they're working on a plan to get the toric implant also. There's a question on hydrophobic versus hydrophilic. This is a hydrophilic platform. Still has a nice low incidence of PCO, and a nice glistening free optic with no inflammation problems. We've had very good luck with the material. And as far as the staff accepting and integrating a new IOL into the practice, they love it when we add another implant to our library. Right. So there are a lot of there are a lot of options, especially in a practice that wants to offer a lot of them, and it really is a menu. But this happens to be one that is real intuitive with the staff, especially. I mean, I spend time educating them, just like we did for this webinar, with this idea of going to absolute presbyopia with a traditional monofocal, and the range that a lens like this gives, and the idea of not having to do with absolute presbyopia monovision that a lot of patients just don't seem to like, whereas with a lens like this, where you're getting that 1.25 of EDOF, the monovision works better too. And so, our staff really is proud to be offering the most advanced, technologies. And I think that, on that, as far as how it compares to other lenses out there, do you guys have any comments on that?
I think it's very similar to the Vivity. It does not perform quite as well as the Vivity does for me, but it is very close. The Panoptix, of course, is going to be a lot stronger in terms of reading, but you get a lot more of those nighttime aberrations, glares, and halos. I haven't used the iHance much, so I can't really speak to that.
Jerry, any comments?
Yeah, yes and no. I think I haven't compared it with iHance. I do a lot of iHance. The reason is, if a patient wants monovision, I do RayOne EMV. So I have more firsthand experience with patients who are happy with the near vision. So that's a little bit biased patient selection. So anecdotally, I like, I'm seeing more patients with RayOne EMV who are happy with near vision, but because I've picked more patients to do monovisioning, okay? So with the Vivity, I think Vivity has a stronger near vision, okay? And not as strong as, of course, the multifocal, the trifocals, bifocals, but it's a different conversation. We need to grow the market share really by upgrading patients from the basic IOLs to these more value-added technology packages that are mid-level. We are not trying to downgrade patients from higher technology packages to the mid-level. So, like I said, Rayner has a robust line of products, and in the hopefully near future, they may very well offer these technologies in the U.S. market. So, my caution to myself and to my staff and to my colleagues is that we need to raise the market up from the basic technology. We increase the pie, we increase the conversion rate. There's no need to cannibalize our premium business by trying to replace them with a mid-level market segment. So we can all be winners. So Vivity has its place. That's FDA approved presbyopia mitigating IOL, and of course with that there's patient expectation, and if they don't meet the expectation, there's a whole different issues to deal with, challenges to answer. But RayOne EMV is sitting in a very nice place, because it doesn't have the indication for presbyopia. So I am personally not offering, I'm not advocating that. But when patient gets that, they're happy. So it's actually it's a sweet spot.
Yeah.
It's important. You always want to balance. You don't want to take away from the set of patients that would want a full advanced technology lens.
Exactly.
But it is kind of a dance to try and make sure that the conventional lens patients are the ones that are going to be choosing the Rayner lens. But at the same time, it is a balance, because I find that I want to make sure that patients are going to get exactly what they want. So I personally usually will just try and gauge what their reading expectations are, and what their dysphotopia expectations are first. That's my first thing that I address with them. And usually if they're looking for reading, I will immediately go to the Vivity or the Panoptix lens. And then if at that point they're concerned about the cost, that's usually when I'll go back down to the Rayner as an option. But I'll go initially to those others. If the patient thinks that they're not going to be interested in reading because from the get-go they don't think they can afford one of the more premium lenses, then I'll talk about the conventional lens first, and then give them the Rayner as an option, because it's available. I have a couple other things I really, because I was listening to Jerry and things were popping in my mind. Number one, I wanted to say that that thinner tip, as you said, it really does help with the post-operative discomfort. And I think that's because there's so much less wound distortion. The day of surgery, I think wound distortion a lot of times can give people that achy eye and that stingy feeling, and you don't have any stretching of the wound. It's very easy to put the tip in. And then the post-op course after that is a lot easier. As you said, the haptics are very good at centration, and I'm very excited for eventually when Rayner comes out with a toric lens, because it's really going to be helpful. One thing I would mention is that whenever you are putting a Rayner lens in, the haptics are thicker, because they're wider than a lot of other lenses. And for that reason, I usually will consciously make my capsular rhexis just a little bit larger, just because it makes it easier to get that trailing haptic in if the capsular rhexis is a little bigger. I wouldn't do that if I was doing a toric lens, because you want good centration. And so for toric lenses, I'll usually make the capsular rhexis slightly on the smaller side, just so that that anterior capsule is helping to maintain the lens stability. But with Rayner, it doesn't matter if the capsular rhexis is bigger, but it's just nice to know that that is going to help you with the implantation if it is. And then I would say, regarding your YAG rate, I've had only one patient, I think, that I've done a YAG on for the Rayner lens so far.
Yeah, it really does fit beautifully in the capsule. And I think on that note, I think you can, as we summarize, I think you can tell we're super excited about this new category of enhanced monovision and an enhanced monofocal implant. And I have, really enjoyed this conversation with you, Michael and Jerry, and you've given me some tips. I think that'll actually enhance my own practice. And I want to thank you for spending time with me, and thank you, Rayner, and I just really appreciate this program. So thanks, you guys.
Thank you.
Thank you, Vance.
Yeah.
Thank you, Michael.